Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today, I want you to picture this. You're on the surgical ward. It's 2 in the morning.
It's always 2 in the morning.
It is always 2 in the morning. And you get a call about the patient in bed 4. He had a big bowel operation a couple of days ago. Seemed fine, but now he's a little confused. Heart rate is just creeping up. And you get that, that pit in your stomach.
It's that quiet moment, the silence before the potential crash. That's where the whole battle is actually won or lost. We're talking about surgical septic shock.
And that's exactly what we're going to unpack today. We're digging into the latest guidelines, specifically the Surviving Sepsis campaign from 2021 and the NICE NG51 protocols, to build a sort of modern survival guide for surgeons and doctors.
It's a race against time, but it's a very specific kind of race. It's not a simple sprint. Think of it more like you're driving 2 cars down the same highway at the same time.
I like that. But before we get the keys to those cars, we have to do the important bit.
The legal housekeeping.
Yes, the mandatory disclaimer. Everything we're discussing today is for educational and reference purposes only. Your patient is unique, medicine evolves, and you must follow your local hospital guidelines and protocols in your clinical practice.
Absolutely. Use this to sharpen your thinking, but your local protocols are what you follow at the bedside.
Okay, so let's get into the meat of it. You mentioned driving 2 cars. The literature I was reading calls this the parallel track emergency, and it really reframes the whole problem, doesn't it?
It's a fatal trap if you don't.
Yeah.
The old way of thinking was linear. Step 1, stabilize. Step 2, operate. But that doesn't work here.
Why not?
Because you have 2 emergencies happening at once. Track 1 is the physiology, the crashing blood pressure, the failing organs. You have to resuscitate that.
Sealing the tanks, squeezing the pipes.
Exactly. But track 2 is the source. The hole in the bowel, the abscess, the necrotizing infection. If you only resuscitate, you're just pouring water into a sinking ship without plugging the hole.
But on the flip side, if you rush a patient with no blood pressure to the operating room, they'll just die on the table.
Precisely. You have to do both, and you have to start both now.
So let's define the enemy here. We use the word sepsis all the time, but septic shock is a very specific beast, isn't it?
It is, and the definition is critical because it dictates how aggressive you need to be. It's sepsis, yes, but with profound circulatory, cellular, and metabolic abnormalities.
Okay, so what are the actual criteria?
There are 2, and this is key. They have to be present despite adequate fluid resuscitation. First, you have persistent hypotension, low blood pressure that requires vasopressors to keep the mean arterial pressure, the MAP, at 65 or higher.
And the second word?
A serum lactate greater than 2 millimole. I really want to pause on that for a second.
Yeah, let's do that. Because I think lactate is often just seen as the sepsis number.
It's so much more. Lactate is the exhaust fume of a suffocating cell. It's telling you that even if the blood pressure monitor looks okay-ish, the cells are not getting oxygen. They're in crisis. That is shock.
Wow, so it's a sign of a hitting crash. And surgically, we usually have a pretty good idea where it's coming from.
Oh, yeah. It's the surgeon's nightmare list. The number 1 suspect is often the anastomotic leak.
Right, day 3 to day 5 post-op.
Yep. But also a perforated ulcer, biliary sepsis, a big intra-abdominal abscess, or, and we can't forget this one, necrotizing soft tissue infections. The flesh eaters.
So the warning signs, it's not always dramatic, is it? The guidelines talk about just a rising new WS2 score.
A rising new WS2 is a huge red flag, but clinically it's often more subtle. It's the patient who's just a bit off. New confusion, a breathing rate that's gone from 16 to 22. It's that gut feeling. In any post-op patient, you have to assume deterioration is sepsis until proven otherwise.
Okay, so you're at the bedside, you suspect it, the clock is now ticking. Let's talk about the golden hour and the Sepsis 6 bundle.
It's not just a catchphrase. The data is linear. Mortality goes up for every single hour you delay antibiotics and perfusion. So you hit the big red button and start the bundle.
And this all starts with our ABCs, airway, breathing, circulation. But in sepsis, C is where the war is really fought.
A and B are vital, don't get me wrong. If their consciousness is dropping, you protect that airway. You give them oxygen. But C circulation is the main event. You need immediate IV access. 2 large cannulas if you can get them.
Okay, this brings us to a huge practical debate. Cultures versus drugs. The textbook says cultures before antibiotics. But it's 2 a.m., the patient is shut down, their veins are gone.
You can spend 20 minutes just trying to get a flash of blood, and and that's a dangerous 20 minutes.
So what do the guidelines say now?
They've become much more pragmatic. Yes, ideally you get blood cultures first, but, and this is the critical part, if getting cultures is going to cause a significant delay, you do not wait.
You just give the antibiotic.
You give the antibiotics. The priority is getting the drug in to kill the bugs. You cannot reverse death while you wait for a culture result. And remember, we're surgeons. We have other options.
You mean like sampling a drain?
Exactly. Sample the drain fluid, get some pus from a wound, some bile, some urine. The site-specific samples are often much more useful than blood cultures anyway.
Okay. So access is in. Now we fill the tank. Fluids. The magic number is 30 milliliters per kilogram.
It is. And that's a lot of fluid. For an average 70-kilo person, that's over 2 liters. That needs to go in fast within the first 3 hours.
But what fluid are we giving? This is where I see a big gap between the evidence and the ward. I still see bags and bags of 0.9% saline.
Me too. And the guidelines now weekly recommend we use balanced crystalloids instead.
Yeah.
So things like Hartmann solution or plasmolite.
So why? What's the beef with normal saline?
The beef is chloride and acid. Normal saline isn't normal at all. Its pH is about 5.5. It's acidic. When you pump liters of that into someone,
You're giving them a hyperchloremic metabolic acidosis.
you are. And the patient is already acidotic from the lactate. The last thing their poor, underperfused kidneys need is another acid load to deal with. Balanced solutions are just physiologically kinder.
Marinating the kidneys in acid. Okay, that image is going to stick with me. But there's also the risk of giving too much fluid, right? The over-resuscitation problem.
Oh, absolutely. Fluid stewardship is the other side of that coin. Once you've given that initial bolus, you have to be smarter. You can't just keep the taps wide open.
Because that leads to pulmonary edema, bowel edema.
The boggy bowel. It swells up, and then you can't close the abdomen after surgery. It's a disaster. So after that first hit, you need to use dynamic measures to see if they actually need more.
So not just looking at the blood pressure.
No, blood pressure is a lagging indicator. You do a passive leg raise, lift their legs up, dump 300 mils of their own blood back to their heart. If their cardiac output jumps up, they're fluid responsive.
Give them more fluid.
Give them more. If nothing changes, their tank is full. Stop the fluids.
Okay, so the tank is full, but the pressure is still low. Time to squeeze the pipes. Vasopressors.
And this is where we have to bust a huge pervasive myth.
The central line myth.
The central line myth. The idea that you absolutely must have a central line in before you can start norepinephrine.
I hear it all the time. Can't start pressors, waiting for the CVC.
That delay kills people. The 2021 guidelines are explicit. It is safe to start vasopressors through a good, large peripheral cannula for a short period of time.
So a big cannula in the elbow crease, start the norepinephrine, and then sort out the central line.
Yes. Restore the perfusion now. Don't let the brain and kidneys die while you're fumbling with an ultrasound probe. Get that MAP back up to 65.
Okay, fluids are in, pressors are running peripherally. Let's talk antibiotics. In surgical sepsis, we're thinking gut bugs, right?
Mostly. So you need good gram-negative and anaerobic coverage. A workhorse drug is piperacillin tazobactam. But you have to think about risk. Is this a community-acquired problem, or is this that anastomotic leak in a patient who's been in the hospital for a week?
Because then you're worried about resistant hospital bugs.
Then you might need to escalate to a carbapenem, like meropenem, or add vancomycin for MRSA. But there's a special case I want to highlight, necrotizing fasciitis.
Right, the flesh-eating disease. The antibiotic choice is different there.
It's a crucial difference. You give your big gun broad-spectrum drugs, but you must add clindamycin. And not because it's the best bug killer.
It's because it stops the toxin production.
It turns off the toxin factory. The bacteria, especially strep, are pumping out toxins that are literally dissolving the tissue. Clindamycin stops that. It buys the surgeon time.
Which brings us perfectly to the surgeon's role. Source control. This is our parallel track. This is the decisive intervention.
It is. All the drugs and fluids in the world can't sterilize a football-sized abscess or patch a hole in the colon. You have to physically, mechanically fix the problem.
And the data on this is it's staggering. Getting source control within 6 hours makes a huge difference.
A 29% reduction in 90-day mortality. That's almost a 1 in 3 improvement in survival. But this is the point of maximum tension. You have a critically unstable patient, and you have to take them for surgery.
Right, and they have to survive the trip to the CT scanner first.
The radiology dungeon. It's a terrifying place for an unstable patient. But for surgical sepsis, you almost always need that CT scan with contrast. You can't operate blind.
So how do you manage that?
You resuscitate on the move. The infusion pump comes with you. The airway gear comes with you. You treat the CT table like it's an ICU bed. You don't pause resuscitation for the scan.
Okay, the scan confirms the worst. You're going to the operating room. This is where we need to talk about damage control surgery.
This is so important. In a stable patient, you do a perfect, beautiful operation. In a patient with septic shock, they're in what we call the lethal triad.
Hypothermia, acidosis, and coagulopathy.
They're cold, their blood is acid, and it won't clot.
Yeah.
If you try to do a 4-hour complex reconstruction on that patient, they will die on the table.
So what's the damage control approach?
You do the absolute bare minimum to save their life. Get in fast, find the source of the contamination, cut out the dead bit of bowel.
But you don't join it back together.
You do not. You just staple off the ends, you wash out the pus, and very often, you don't even close the abdomen. You leave it open.
Really? Just leave it open?
Yep. Put a temporary vacuum dressing on it. Get out of the OR, ideally in under an hour. Get them to the ICU to get warm, correct the acidosis, fix the clotting.
And then you plan to go back?
You go back for a second look laparotomy in 24 to 48 hours. When they're stable, then you do the fancy reconstruction. The mindset has to be, I am not fixing anatomy today. I am stopping a physiological disaster.
Wow. So the brave decision is actually to bail out early.
It's the smartest and bravest decision.
Yeah.
A quick, messy operation saves the life. A slow, perfect operation on a dying patient kills them.
Okay, let's fast forward. They're in the ICU. They've survived the operation. What about things like steroids? I feel like they've gone in and out of fashion.
They have. But the 2021 guidelines suggest giving IV hydrocortisone to patients with refractory shock.
Meaning they're still hypotensive on high doses of pressors.
Exactly. If you're cranking up the norepinephrine, their own adrenal glands might be exhausted. The steroids just help support the blood pressure and can get them off the vasopressors faster.
And what about the antibiotics? We hit them hard at the start. Do we just continue those for 2 weeks?
Definitely not. You review every single day. If your source control was good, you drain the pus, you remove the dead tissue, then a short course of 4 to 7 days is usually enough.
Okay, but here's the scenario that every surgeon dreads. It's day 3 in the ICU, and they're not getting better. Lactate's creeping up. The knee-jerk reaction is just to add more antibiotics.
And that is almost always the wrong move. This is a critical point. If a surgical sepsis patient isn't improving, it's not a drug failure. It is a source control failure.
You missed something.
You missed a collection. There's another abscess somewhere. Do not just change the drugs, re-image the patient, repeat the CT scan. The answer is usually a drain or a scalpel, not a different antibiotic.
Source control failure until proven otherwise. I'm going to write that down.
It's a good mantra.
So before we wrap this up, I want to zoom out a bit. We talk about survival, but survival isn't the end of the story, is it?
Not even close. We're seeing more and more post-sepsis syndrome. These patients have been through a physiological hurricane. They often have long-term cognitive problems, physical weakness, PTSD. Recovery takes months, sometimes years.
It's a life-changing event, even if they survive.
Absolutely. We need to prepare families for that long road.
This has been an incredibly practical deep dive. To summarize for everyone listening, what's the mental checklist?
Okay. Number 1, recognition. Think lactate, not just blood pressure. 2, the golden hour. Drugs and cultures, but drugs take priority. 3, fluids. 30 mils per kilo of balanced crystalloids. 4, pressors. Start peripherally, don't wait. 5, the parallel track. Resuscitate while you investigate and get to source control within 6 hours.
And 6.
6, the surgery. Damage control. Stop the contamination and get out.
That's a fantastic summary. And a final provocative thought to leave everyone with. We spend our whole careers learning how to be technically perfect surgeons, but these guidelines seem to suggest something else.
They really do. They suggest that the most important surgical tool isn't the scalpel, it's your brain. The decision to operate and the speed of that decision has a bigger impact on survival than how perfect your suture line is. A fast, good enough operation now is infinitely better than a perfect one that's 3 hours too late.
That is a powerful place to end. We really hope this gives you a bit more confidence for that next 2 a.m. call.
And hey, if you found this useful, if it helped connect some dots for you, please do us a favor. Share it with at least one colleague or friend today. Text them the link. Spreading this knowledge is how we actually make a difference on the wards.
Absolutely. And don't forget to check out our YouTube channel and other social media pages for some visual aids on the Sepsis 6 and damage control principles. Thanks for listening.
Stay curious.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe.
Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.